Okay. Well, good morning, everyone. My name is Bill Kelly, and I'm the co-founder and CEO of ReelDx. You have joined us this morning to participate in our webinar called Making It Real in the Virtual EMS Classroom. Welcome. Thank you for spending your time with us this morning, and we will try to deliver something that's valuable to you and hopefully helps you improve your teaching and learning in your classrooms. I'd like to introduce the panelists that we have today. We are joined, here let me share my screen. We are joined by two faculty members and two students from Central New Mexico Community College from their EMS program. Joy Cherry is an Apple Distinguished Educator, and is on the faculty at Central New Mexico Community College. Leslie Faust is also on the faculty at Central New Mexico Community College and teaches in the EMS program there. We also have two students from their program. Ian Whaley and Nora Nimmer are both second-year paramedic students at Central New Mexico Community College, and just this morning, I believe, finished their finals for the current semester. So they are feeling good today. So we welcome them, and thank you all very much for being willing to participate in this webinar this morning. I'd also like to thank the NAEMT for allowing us to put this on and co-sponsoring the event with us. They've been terrific to work with, and we encourage you to support the NAEMT as much as you can. All right, so let me tell you how we're gonna do this webinar today. I'm going to run through a very brief demo of ReelDx just to help people understand what the program is and how it helps in classrooms. Then I'll turn it over to Leslie, Ian, and Nora, and they will walk us through a demonstration of teaching and learning using real patient video cases in an online environment. When they're finished, Joy will come in and walk us through a little bit of educational theory, particularly about Bloom's taxonomy and how that relates to the use of case-based learning in any kind of classroom, including online. So we'll proceed that way. Let me share my screen with you and walk you through a quick demo of ReelDx. Just by way of background, ReelDx has been providing online libraries of real patient video case studies since 2013. We have a library of close to 700 cases that are captured by real clinicians in a variety of settings, including clinical and preclinical settings. And these feature real patients exhibiting real symptoms. They're not staged, they're not actors. And for that reason, we think we're different. We think it provides an interesting way to bring real world cases into your instruction at any level and in any part of the educational sequence. Just by way of walking through this real quick, this is what it looks like when a faculty member logs into ReelDx. All of the cases are available on this view, and you can search by symptoms or by demographics or anything that you would like. As I said, there are nearly 700 cases in the environment, and you can also organize them into courses that you assign to students and allow students to independently access these cases. You can control the sequencing of the cases, when they're visible and when they disappear. And you'll note that in each case, we have an anchoring video as well as drawers that feature case data, including vitals and demographics, a differential diagnosis workup, the final diagnosis, actual outcomes, etc. As faculty, you have control over what aspects of any case are visible to the students at any time. Let me just briefly play this video, and I'm going to skip forward so you can see these emergency responders.
Noticed it, and I don't know how long it was going on. I don't know how.
25 after.
14:25. So I think it was probably 2:15, 10, 2:15 probably.
Okay,
so I only show that to really reemphasize that these are real cases taken in real settings with real patients. We secure patient consent. So every single one of these cases, we are presenting with the consent of the patient. And we include in that consent form the ability for the patient to rescind their consent at any time. It's never happened, but we do take seriously patient privacy and patient consent. So with that demo, I would like to then turn it over to Leslie and the students from Central New Mexico Community College.
Thanks, Bill, for that introduction. As Bill was mentioning, there's over 700 cases, so you get multiple different pathologies, and each case has drawers that have certain specific patient information in it with age, what's going on with the patient, what happened, what was the differential diagnosis, and what was the final outcome of the patient. That's incredibly valuable for you as the instructor to prep your cases ahead of time. And then it's also really valuable if there's a multitude of ways you can actually use that tool in the classroom. You can either use it in the virtual clinical classroom, the virtual theory or actual face-to-face theory classroom, and also in lab. Today, we're going to demonstrate how to be a lead paramedic on a scene, but there's a multitude of ways you can integrate ReelDx as far as the things you want to use at all levels, EMT basic all the way up through paramedic. You can do team lead, you can do pathologies, which we'll focus on primarily today. You can do scene safety. What I love is the case that Bill just showed you is a great case to talk about therapeutic communication and the integration with coworkers. So I'm going to share my screen and we're going to start going on this. All right. Ian and Nora, you guys are dispatched to a 30-year-old male who is unconscious and unresponsive at a nearby park, and PD is on your scene. So we're going to take a quick look to see how this looks. So that's your scene. Just looking at your scene, you're more than your windshield view because you're out of your vehicles at this point. What scene concerns do you have and what do you want to address?
All right, so, scene safety. We see that there's PD there, so we can assume the scene is safe currently. We'll reassess this throughout the scenario or the case. Also, it looks like we are in an industrial part of town, possibly a park next to that. So that's something that we can look at as well. There's no crowds currently, but we do have PD there. If we need to control the crowds, we can send them over. So.
Okay. Nora, with just the dispatch information, what do you want to bring in on this scene, equipment-wise?
Equipment-wise, I would grab my gurney just in case we need to transport this patient. My cardiac monitor would be very helpful, as well as any medications or airway equipment. He is unresponsive, so I don't know if he can maintain his own airway, so that would be helpful.
Okay, let's hop on the scene and see what more information we can gather.
Check his pupils. Kind of slow respiration, got a good pulse, pinpoint pupils.
Okay, we've got just pretty much about a 25-second view, which should be able to give us a couple of things really quickly. Ian, what information could you gather? What do you see? What do you want to, what have you got in that's going to make you start thinking about rule in and rule out things? Yep, unmute yourself, Ian. There we go.
So right off the bat, we already started getting some ABC information. We do see that he is being bagged by one of the providers, so his airway is being controlled. They did say he has a pulse. So walking up onto the scene is good to just reassess that, because just because they checked it, we don't know when they last checked. So I think that's a great idea to recheck. Also, they said there's pinpoint pupils, which right off the bat, he's unconscious and he's in respiratory distress because he's being bagged. That's leading me towards a narcotic overdose.
Okay. I think those are really good observations as well. With that information, Nora, what are the very first things you want to do for this patient on your scene?
Yeah, of course. So I'd want to hook him onto a cardiac monitor, just to rule out any of my AEIOU tips. I see that he is bagging him. A simple airway adjunct, maybe an NPA, maybe not an OPA, just in case they want to give Narcan to reverse a possible narcotic overdose. We don't want anything in his mouth so that he can aspirate in any way. So an NPA, an N tidal would be good. Yeah.
Okay. All right. Is there any medications you want to start giving? Do you want IV access?
I think IV access would be great, and Narcan.
Okay.
Those are
All right.
Check his pupils. He was in the bathroom here for a while, so it's pretty obvious. Yeah. Get a line. Scott's got it. That's one right there. Turn it on. Yeah. Yeah, they go.
All right, so it looks like so far they've done a couple of the things that you guys were also thinking of. I see high flow oxygen being administered. It looks like they're starting to get an IV. I believe this provider is measuring an MPA. I'm not quite sure. I think we're gonna have to watch for that. There was a bit more information that they gave you. So at this point, what additional information is starting to get you to focus on one pathology versus another?
I think, the environmental clues, they said that he was in the bathroom for quite a while. So I think it would be great to possibly send a provider with a police officer just to go to the bathroom, see if there's any sort of paraphernalia there, which could also lead us even further down the road of an opiate overdose and, ruling out other AEIOU tips.
Okay. Nora, I know you had suggested an MPA, and I think, like I said, I think they're doing that. Is there anything else you want to use to address that airway or any concerns you're going to have with that airway?
We should always have the concern of like aspiration, but they seem to be handling this airway properly. Hopefully he is measuring an NPA and getting that in. Again, I'd look for any acidosis because they're breathing for him.
Okay, so how would you look for that?
Your ETCO2, so your capnography.
Yeah, so getting him on end tidal sounds like a good idea. It seems like it's taking him some time to get an IV. How do you want that Narcan? Are you guys ready to give Narcan? And if so, how are you going to give it and how much are you going to give?
I think ideally it's going to be intranasally initially because it seems like they're having a difficult time and you don't want to delay giving that Narcan because that could reverse the narcotics. Also, we're going to give 2 milligrams.
Okay, let's see what happens.
Capnography.
So Nora, look, there they go for that capnography. We're dead on with that. And there is an NPA currently being placed as well, so good call there.
Whichever one first. Okay. Right nostril's got it in either one. Go left. Yeah. His left or my left, Your left. Alright, ready?
And there looks like there's that 1 milligram of Narcan.
Get that line.
Intranasally.
Narcan. So got a half in nasally. 176 on blood sugar. Got waveform on that cap.
So it looks like the blood sugar was 176.
You want it? You want it on? It's on. There's the waveform. Got it.
All right, so we're about a minute into them giving that intranasal Narcan, and we've got no changes in increase of respiratory drive. It looks like also that they've checked a sugar. What do you think's going on? Do you still think that you're on the right track? Are there other things you want to rule in, rule out? What's happening?
So they already ruled out hypoglycemia. 176 is within a good range of blood sugar. I don't think they got an end title yet. I would still continue checking for that and any other AEIOU tips.
Okay. Ian,
Right.
what do you think?
Right, and to add to that, this could be a synthetic opioid, which is going to require more Narcan to knock it off the receptor sites, as well as he could have excess mucus in his nares, which is also going to prevent the Narcan from getting absorbed.
All right, let's see where they go from here. So we're going to give that a second dose of Narcan.
If he doesn't improve, his end title is like 81. The belly's moving. Yeah.
All right, sorry. It looks like they're, we're gonna speed up just a little bit for time's sake and so we can finish off our whole webinar. But so they've given a second Narcan and there's still no intervention. They're having a really hard time getting an IV. Why do you think that is?
I think the patient could be dehydrated, which is going to cause a difficult time getting an IV. Also, if he is a known IV drug user, you're going to have scar tissue built up on those veins, which is also going to make it very difficult, and they can roll.
Okay. Do you agree with that second intranasal Narcan? And do you guys think that they should have had an effect with that? Do you think that we're on the right path? What would you continue and what treatment would you want to continue rendering?
His respiratory rate is super low, like they're still bagging him, and his end title is actually really high, which is concerning. They also said something about his belly moving. So I'm thinking the air isn't going down his trachea like it's supposed to, and it's going down his esophagus, which is also really bad. I think they need to readjust this airway, or there's a lot of providers, so I would even have 2 people on that airway.
Okay, yeah, I agree with you. So I'm going to tell you, just like I said, for time's sake, we're gonna advance this a little bit, but they finally get IV access at around 7 minutes in. With that IV access, what do you guys want to do? Do you want to stay on the route of administering Narcan, or is there something you want to change? Is there anything you haven't ruled in or ruled out yet?
I would like to continue on the route of opioid overdose and give Narcan IN or IV.
Okay, Nora, do you agree with that, or is there something else you want to look at?
Yeah, I completely think this is a narcotic overdose. I think IV would be sufficient for that Narcan, just because also I don't think it's getting to the receptor sites. So
okay, so we're going to jump up to 7 minutes and after they get an IV, and let's see if they address any of those airway issues that you were talking about, Nora, with working on the ventilation and readjusting that airway. Quick question though, is there anything you can do to also reduce that end tidal? Aside from having 2 people on the airway, you've got your simple airway adjunct in, repositioning the head, what else can you do? How do you want to ventilate them?
you can also increase the ventilations.
All right, okay, let's see where they go. So, like I said, they got IV access.
The blood sugar was normal.
It looks like they're doing the same things, going down and making sure, let's rule things in and rule things out again.
Still not moving around here? Yep. Gonna flush.
Yeah.
Okay, 2 more on.
So he's now, will have had 4 milligrams of Narcan, 2 intranasally and 2 IV.
Doing a good job.
Yeah, Nora, they're looking at that end tidal as well. Look at that. They're repositioning the airway. I think he's bagging a little faster for him. Getting a 12 lead.
Covering spontaneous respirations. Guy's getting that. If he doesn't recover from this, we'll just throw him on the.
Oh, there it is.
Easy. You're all right.
Relax. Lay back.
Yeah, I'm good.
Lay back.
Okay, so it looks like, what do you think happened? Why is he all of a sudden awake, talking to you? Tell me are your interventions working? What are your concerns at this time, Ian?
I think the interventions are working, especially going IV. It's a surefire way to get to the receptor sites, especially because the patient does have a pulse. I would be concerned with seeing safety now. You know, I said in the beginning we're going to reassess, and now that we have a new patient, we didn't get a number for what his end tidal was, but they said it was bringing it down, but he could still be hypoxic. So he seems very confused. He could also become combative. So I think it's great that there's, providers there maintaining control of the situation and, telling him exactly what's happening, informing him, and, just maintaining control. I think that's the best thing for this patient at this moment.
Fantastic. Nora, what do you want to do with the patient? What other treatment do you want to render? What additional assessments do you want to do?
Yeah, so I would like to reassess my primary, look at his ABCs again. He is breathing on his own. I want to see if it's adequate. His skin color. I would also do a whole secondary, look at him head to toe and transport him, of course, get a better history, see what he took, if any underlying diseases he has, and just monitor his vitals en route.
Fantastic. You guys did a great job. You identified certain things that were concerning on your scene. I think you addressed the airway and continually reassessed it and made changes as the case continued, as well as thought of outside things that could be causing the unresponsiveness. I think also, Ian, you hit on, as he gets up, he is still very hypoxic. And at that point, he's confused and can be easily combative, which makes it a very unsafe scene and something you can continue to consider, right? Your scene safety doesn't end when you enter the scene. Like you said at the very beginning, it continues throughout. And this is a prime example of that. Nora, I think you hit on, absolutely reassessing him from head to toe, finding out information, but understanding that my information might not be real accurate until he is actually not hypoxic anymore, but not just get pigeonholing yourself into one pathology. Great job, guys. Thank you so much. So that's basically a case presentation that we would normally do in the lab class, in the virtual classroom or virtual clinical. The best part of this is that Joy, I'm going to pass this on to Joy Cherry, who's going to explain how this really affects you as an educator and how it hits Bloom's taxonomy. Joy, they're all yours.
Thank you, Leslie. Ian and Nora, you guys did a wonderful job. Obviously, they're kind of toward the end of their paramedic education because they were able to work through that case pretty flawlessly. And we can also congratulate them because they are entering their last term and they will graduate on time. We're happy to report in December, and despite COVID and all of the setbacks we had this summer. So we're very happy for that. Thank you, Leslie. I'm going to be sharing my screen with you guys. I'm going to talk to you briefly about how case-based instruction works in the Bloom's taxonomy and educational theory. And so we're going to talk about it briefly, and hopefully you guys will start to see how we have developed this case, and you guys, how we've developed the program over the years. Starting in 2012, we started integrating iPads into our classroom. And every student was issued an iPad, and this was really initially to start doing things like data tracking. That was kind of our goal, and also to be able to do electronic charting. And so as the program developed and students started using different things, we started getting different ways to use the iPad, and one of the things that came up was ReelDx. And so in 2014, we were first introduced to this program, and we started integrating it into our curriculum. So that's a little bit of our history and how we ended up with ReelDx. I'm gonna talk to you guys about how case-based instruction actually supports educational goals and what we are doing in EMS education. Bloom's taxonomy is something that may be review for educators. We probably have a lot of educators on here who have a lot of experience, but we probably have educators who have almost no experience. So many of us came straight from the field from EMS, and we were told go teach this class, but we didn't have the educational background to be able to do that. And so we learned lessons the hard way. And so hopefully this will introduce you and kind of offset some of those lessons. Bloom's taxonomy is an educational theory that was first introduced by Benjamin Bloom and David Crothwell in 1956. It's had many iterations since then, but it has been stayed tried and true in education. And what it is, it's a cognitive learning framework. So if you think about remember as a way to, as a baseline of education, beginning education, and then create as expertise, you move up the triangle as you stay in EMS and as you teach and as you learn. And so these different learning planes are what we are trying to achieve in our educational EMS education. So consequently, each of these learning planes have verbs associated with them. So when you guys are writing learning objectives and you're trying to figure out what do I want the student to achieve out of this lesson, you would go to say, oh, I want them to be able to analyze and evaluate. Then you would use verbs from those learning planes in order to create your learning objectives. And if you just Google Bloom's taxonomy verbs, you'll come up with a billion options for you to choose from. So getting into this a little bit, if you at the remember phase, this is recalling basic facts. And then the next phase is understanding phase. It explains ideas and concepts behind the basic facts. So we do this. This is a good chunk of what we do in EMS education and EMS theory courses. So most of your basic facts will be introduced in theory, but you also do have some basic things that are introduced in labs. So for example, you're teaching them how to take a blood pressure. You're teaching them how to backboard, or well, not so much backboard anymore, but starting IVs. And then you kind of explain why we would start IVs and we get them started on those concepts. And then as you move up into the learning planes, you start doing application level. And you want them to take the information that they learned in their theory courses and take those skills, and we want to use that information and put them into new situations. And the way we do that is providing them scenarios. And so if you guys are, for example, just teach about narcotic overdose, this is a great case to pull up. And in class, I'll introduce them to the signs and symptoms and the pathology behind a narcotic overdose. And then I'm going to pull up a ReelDx case and show them a video so they can start applying that information right away and integrating that information. And ReelDx provides you with approximately 700 cases, different sites such as clinics, rural medicine, EMS, ER. And so you guys have a variety to choose from. And then we want them to take that information and we want to transfer that learning from one situation to the next. And so we start giving them simulations in lab, and this all culminates into capstone and internship. While we're giving them the scenarios, we want them to make connections between ideas. So they start taking that information, they not only apply it in scenarios, but they start formulating rule outs. And I think Ian and Nora did a really good job of showing you guys and demonstrating how they did that, even from the beginning of the scenario. And they started formulating and implementing their treatment plan. And as that treatment was rendered, they started analyzing, is that treatment plan working? And this is exactly what we're doing for students in the lab room. And then at the end of your scenario, or at the end of a call, depending on what setting you're coming from, you want that student to start justifying their decisions. And so what I do, and this is an important piece of the education, is we really want the students to self-evaluate. I do this first because I want to be able to identify any holes that they may have, and I want to see if their thinking is actually correct, if I need to redirect them. And then when I start giving my feedback, after they've given their self-evaluation, I want to give them their feedback, and I want to sandwich it. And it's a positive, then a negative, and then the positive. And So I always start off, this is what you did really well during this scenario. This is what went well during the call. And hopefully this kind of feedback is translating into the field. We should all be analyzing our calls after it happens. So we start off with what went well, and then we start talking, okay, this is the holes and gaps you have, or this didn't go well, and we start redirecting the student. And the way I might do this, I always want to redirect them in a positive way, because I want them to be able to achieve goals and look for goals to work toward. So for example, if I have a respiratory scenario that I just gave them and they were supposed to give epi to that asthma patient and they didn't, I'm going to tell them, all right, you missed your epi on this call. This is why the patient needs to get it. I want you to go study your respiratory treatment guidelines because you're missing that piece. And then at the end of it, I want to reiterate what I want them to keep. And the reason why I end with that and not with the negative is because if we end with the negative, students will walk away, and not only will they try and change the negative, they'll also change the things that were good. So I always end, I want you to keep these things, I don't want you to change them. And then finally, we hit the create. This is where our wheelhouse as educators. This is where 90% of our effort goes. This is what we work toward. And this is producing newer original work. And this is really to support the student and all of the other learning planes. So ReelDx supports you in this by doing the creation work for you, which for me is fantastic because sometimes I need something quick and I don't have time to create, but I can pull and draw from this resource. And as you guys can see, it's been facilitating our virtual learning, but it's always supported our classroom learning as well. The nice thing about ReelDx is that they're learning from experienced providers. So they're working on team dynamics. They're good examples of how a team would work together. These providers also are excellent history takers. They're great investigators. They always ask questions. The students get good examples of what questions to ask and when and what order and when it's important and when it's not. And it also allows them to start witnessing how scene management takes place within a variety of settings. And that's the wonderful thing about EMS, and even having doctors and clinicians be doing these videos, because you can learn from those experts as well. And the hard thing I think that we have that we're always aiming for is therapeutic communication. We give them feedback on this, hopefully in every scenario, and hopefully the internship experience helps build those skills. But at least the students start building or start looking at these experienced providers and see how they communicate with panicked and angry and despondent patients. When I first learned about ReelDx, this was probably the most important thing that I was after. I have a very hard time simulating what it actually is like in the field. No matter how many times I painted that pink mannequin white, it just didn't do the same as actually seeing a patient. All of us as experienced providers, we walk into a scene and we have a catalog of visual cues from previous patients that we've run, and those visual cues help us clue in on what's going on with the patient. So if I have a patient who's sitting in the corner and he has a 100-yard stare and he's diaphoretic and he's pale, I'm gonna go, I need to take a blood sugar on this patient, just based on the fact that I've seen this patient 50 other times on 50 other calls. So this is what ReelDx starts to do with your students starting in the classroom. It starts building their catalog of visual cues that they can draw from later on. And those visual cues bring actual real-world application into the field, into the classroom and into your lab rooms. And no matter how many times we get that mannequin out and we can do really good simulations, it's just not the same as all of the team dynamics and all of the dynamics of a scene that get pulled in the real world. So hopefully that starts to offset some of that simulation, and we can start building those students up. And so this is a basic introduction into Bloom's taxonomy. I think we're going to go into questions. And I believe that Kat is going to be facilitating that, and Bill as well.
Thank you so much, Joy, and thank you, Leslie and Ian and Nora for all of that. I think it's very, very valuable. I would like to first of all acknowledge that we've received a lot of questions on the basic chat, and thank you very much to the attendees for those questions. I wanted to hit, excuse me, hit a couple of those questions directly because I think they'll be of benefit to others who are attending. And then there is a couple of questions that have come in that are about how to teach and learn with this, and I'd like to turn those over to Leslie to address. So first, let me just say, we've received a bunch of questions about pricing. We're happy to share pricing information with you. We'll reach back out to you based on your specific questions, but to everybody as well, giving you some instructions about how to get a demo and how to get pricing for ReelDx if you're interested in using it for your program. We've received a couple of questions about specific features. I wanted to address those. One is about closed captioning on the videos. Every video goes through a closed captioning process, as you can see in the video that was used in today's demo. Some of the audibility is problematic in these cases in the field, but we do our best to get the details right and to make sure that there's a closed caption feed in each video. So they're 508 compliant. Secondly, we were asked if we integrate with learning management systems. Today, we do not explicitly integrate with learning management systems, but that is literally the next technology development that we're doing for the rest of the summer. If you are interested in integrating ReelDx into your learning management systems, please let us know. We'd love to get your feedback on that so we do it right and do it in a way that is beneficial to you. All right, with that said, then there are a couple of questions on the Q&A board, and I invite all the attendees to submit any additional questions you have on Q&A. Leslie, do you want to repeat the question that's been asked and then go into your answer?
Yeah, absolutely. So Earl Wilson asked, how do you handle when a student wants to do something that is correct but not done on the video? For example, what if the student initially wanted to give intranasal naloxone? It happens all the time, and it's a wonderful teaching point. You know, it's so easy, and it's important on several levels. One, it's really easy to sit back and say they need to do this on scene, and forget that they're working through stuff. And it's great to equate that when you're actually in the heat of it and you're doing multitasking, how really efficient are you at multitasking? And is that something that was maybe a team leadership issue that needed to be done? What were the things that had maybe indicated why they looked at something to do something first or not at all? Or when something should have been done? And yeah, actually there's some cases where there's actually some poor treatment done. And so it's fantastic because it shows that we're not perfect. The ReelDx cases are very real. You'll see bad interactions amongst providers. You'll see things that either get missed or aren't redirected appropriately. And that's what happens on scene. And the way I equate it to my students is that unless you absolutely go back and look at every call, just like Joy said, and you reevaluate it, you're never going to be a good provider. You're never going to excel at patient assessment. That's probably the hardest thing we do as providers, no matter where you are in level of licensure, is doing a solid patient assessment. So this is a great tool to show them that people that have been doing this for a while still stumble on the same things that somebody brand new does. So that's how I address that. There's another question here.
Leslie, I'm going to add to that too, and I want people, the audience, to know that ReelDx does not shy away from that. So when you get your teaching points in DX, they do point out some of the mistakes that were made in the video, and they give you those teaching points, and they don't shy away from things that happen because they're all important learning. And as Leslie said, even experienced providers, no call goes perfect. None of them do.
There's another question here from Jenna Richardson, which is a perfect question. It's asking, Joy and Leslie, did you use ReelDx to supplement any of your clinical or field internship patient contacts during the pandemic? Oh my gosh, yes. So I had 144 basic students in the clinical setting in March that I had to pull. And they still had to do 12 patient contacts. And I was scrambling going, what am I going to do? I can't give them incompletes. It's 144 students that I got to figure out how to do incompletes with. And so it was ReelDx that solved it. I had an amazing amount of a group of clinical educators that would normally take the students up to a unit, and then they would interview real patients. And so we just flipped it. They interviewed real patients using ReelDx. And that's actually what we did all summer long because we weren't allowed back into the clinical setting. So it was a lifesaver for me. And they actually got a lot out of it. What I noticed was you know, having them face to face in front of a patient is incredibly scary. They're real hesitant to ask questions. When I was using ReelDx, my group of 6 students, everyone participated. Nobody was scared. Nobody like went back and, you know, and kind of snuck behind the group and was quiet. Everyone actually partook because for them, I think it felt more of a safe and easy platform than being face-to-face and being judged. You do miss that aspect of really, you know, touching a live patient, but at least they could get into the role, especially at the basic level of seeing things and knowing what to ask and how those interactions happen with patients. Joy, you want to touch on any of that?
No, because I think that you really did a lot of the legwork for that. There is a question that I want to answer about scoring and grading system for the students, and then also how much of the videos are BLS. So there are ALS videos in here. I think that there was a VTAC case. It's a symptomatic VTAC patient that's in there. So there are a number of cases that are BLS and ALS to work through. And then also in terms of the scoring and grading, it completely depends. Every instructor in our program uses ReelDx to a different point. So Leslie had to use it, and yes, it was part of her scoring and grading system to be able to fulfill clinicals in March and April. But I teach an online course, and when I lecture, I teach GIGU online, and when I lecture on a particular pathology, I have the students follow up with a ReelDx video, and that is completely autonomous. It's something that they do on their own, but it allows them to apply the pathologies that they had just learned. So I think that it's you know, really up to you how you want to score that and how deep you want to go into that. It just depends on what you're using it for.
And I'm gonna, sorry, backtail because I'm watching the chat, and somebody is absolutely correct. So before I moved to taking my students out of the clinical arena and using ReelDx, I absolutely did go to both our medical director and our advisory board, and that did get approved. So it wasn't just us, you know, as the clinical coordinator, I didn't make that silo decision. You do absolutely need to go to your advisory board as well as your medical director to make those decisions. And they realized that that was the best avenue for us to address that at that time.
Great, thank you guys for those answers. We are now at 45 minutes, which is where we had advertised this webinar. So let me make a couple of comments for anybody who does need to drop. We are recording this. We will make this webinar available as soon as we can. The NAEMT is also going to help us promote the availability of the recorded version of this webinar. So if you'd like to share it with colleagues or review any of this, or if you came late, or if you want to listen to any further Q&A that we do, please know that all of it's going to be recorded and available as soon as possible. And so with that, let me just thank everybody who does need to leave. There are a couple of more questions that I would like to stay on and answer. So we're going to keep going here for a couple of minutes, but if people need to drop out, we understand, and thank you all very much for coming. The questions that I wanted to address, there was one question about the breakdown of cases. What percentage of cases are true pre-hospital cases versus the 700 cases in total? I think it's about close to 20% of the cases in our entire library are true preclinical emergency response cases. So it's upwards of 90, 95 cases fall into that category. There's also a large number of our cases that are in the emergency room. So, and often those are emergency room receiving a patient from the emergency response team. So those are also often very relevant for emergency response training. Joy and Leslie, can you comment on kind of the breakdown of cases as you've experienced them as faculty members?
So whenever, I mean, as far as like basic versus pre-hospital versus in-hospital versus clinical, I've used them all. And I've used them all in a variety of ways. For example, I do usually peds OB at the paramedic level. And Bill, you kind of showcase that one case. And for that, I've also used it in the basic classroom. Because especially for pediatric patients, our students get very little pediatric exposure when they're out there in the field. And so it fills that gap. And they're terrified, right? Most of our providers are really terrified of getting pediatric calls because they just don't get the volume of them. So I'll use it both in the basic classroom all the way up to the paramedic classroom. And you can, like I said, you can break down the calls any which way. I've used, there's like a wonderful overdose call of a child that's in a clinic, and he's brought into the clinic in a country outside of the United States. And it really allows you, it gives you some depth instead of just looking at medicine in your area, the way you're running calls. So it's powerful in that sense. There's sometimes I'll run the entire case. Sometimes I'll only run parts of the case to get us an idea. We've used it in testing for integrated out of hospital, where we're like, here's your scene. This is what it looks like. And that way they're not making up this fictitious idea of what the scene looks like in their head. They actually have something to truly evaluate. I hope that answered what you wanted, Bill.
Yeah, no, that's great. Thank you. There are a couple of other questions about the cases themselves. We are adding cases right now. We're adding at the rate of about 2 cases per week. Most of the cases in today's inbound cases are coming from emergency room settings. We are interested in adding more pre-hospital cases, and we'll be turning to our contracted sources. But I'll put it out there that we would be open to new agencies that want to submit cases into the ReelDx environment. So if there's anybody out there that would like to discuss case contributions, we'd love to have that conversation. We do review the cases. We try to review them once every 18 months. We're a little behind right now, so you'll notice some cases that are beyond that 18 months, but we do try to regularly review the cases, both for accuracy, for any updates in presentation or formatting, and for the medicine that's involved. There was a question earlier about whether every case is highlighted for any mistakes that were made. I'm not going to promise that every single mistake that anybody might imagine somebody made during these cases is highlighted and cataloged, but we do have a medical review or medical editorial review process that tries to identify things that are controversial or may be different from jurisdiction to jurisdiction based on local standards. So we do try to make an effort to do that. And obviously any of these cases are going to have to be placed in the proper context by the faculty for standards and protocols used in your local areas. And we know that those do vary from location to location. And part of the philosophy, I should just say, about the ReelDx platform is that it's designed to be very, very flexible in terms of how faculty use these cases. And we acknowledge and encourage you to preview cases before you use them with students. Make sure you know the course of that case, where certain information is presented. Sometimes in the initial video, you'll get more information than you want from an educational standpoint. So you just need to be aware. I'll also comment that although we have worked for years now to gather these cases, by no means do we have a comprehensive library of every possible case. We're certainly lacking in OB cases. We wish we had childbirth cases and late-term pregnancy cases. We're lacking in some psych cases. We would love to have more of those. Some of these are just harder to come by than others. So we acknowledge that. And despite that, we just keep hearing from our customers all over the country and in a wide variety of educational settings that they're very valuable. The library is extremely valuable as is, because it does bring that real world experience into the classroom and into your educational settings. Could we hear from the students? Ian and Nora, would you mind just giving us a little viewpoint from the student perspective, what it's like to have a variety of these cases that you use in your instruction?
Yeah, of course. Joy did do the GIGU, and that's where I was first introduced to it, or I think we all were. She created the shell, and I thought it was extremely helpful. At the time, I wasn't working in the field, so I never really got to see actual patients, like it being a real patient actually having like a pathology that we learned from the book. I'm sure my fellow classmate Ian can talk about how yeah, I don't think he works in the field either, so I'm sure that helps him a lot. And it's just so much better not having to imagine it when you can actually see it, you know.
Thanks. Ian, anything to
add? Yeah, so she's very right. You know, I think most EMS students are visual learners and hands-on learners. So the situation that we're in now, not being able to get our hands on everything, this comes in even more handy than it was. It doesn't change the fact how, you know, good it is for us to be able to go on and like the one that you showcased with the pediatric having a seizure. Leslie said that you know, providers are worried about pediatrics, which is very true. I think that's one of my biggest fears getting out into the field is how do you handle that? Because it's not a call that you would, you know, expect to get. You would expect to get somebody who is slightly older or sick with history, but with a pediatric, you know, and having to deal with the patients and therapeutic communication. That case showcased it very well. The provider stayed calm, and as a student, you can see what you want to pick up from what that provider does. So let's see, did that provider do something wrong? Did they, you know, respond inappropriately? Like, okay, well, I shouldn't respond like that. But not being in that situation, you know, you look at it and you just want to, you know, be as professional as possible, stay calm, even though on the inside you're freaking out. So it shows you that how to model yourself as a student and as a provider. Also, you know, like Nora said, we get to see pathologies of, you know, stroke victims, spinal cord injuries in the clinical setting. Like when we were going through neuro, we were able to see different spinal cord injuries and how they affect the body, which is great for me because just reading the book, that's fine. But seeing a video of somebody saying, yep, I can't feel this side of my leg, but I can feel temperature on this side of the leg. I can feel pain on this side. I can't feel pain on this side. And it's a great resource for me to use personally.
Great, thank you. There are several questions that are probably best answered by me. So let me just tackle them real quick here. One question is, does each video have information on the location of the providers so that they can evaluate performance under the local standards? Yes, each case we explicitly credit who supplied the case and who was the editor of the case. In almost every case, there are also comments that are provided by the provider who took the case and by the editors that reviewed it. So you should be able to tell where the case was captured, which agency the provider worked for. Another question, can schools use one platform for multiple health science programs? It's a great question, and the answer is yes. We have customers in EMS training, in nursing, in physician assistant training, and in medical schools, MD and MDO programs. We have started getting customers this year in medical assistant programs, which we welcome. And part of the pricing is an institutional license. Once that institutional license is paid, any program under that institution can take advantage of that. So by combining with other health sciences programs at your college or university, you can save some money and, you know, share the cost across multiple programs. There's a question about whether agencies use this for continuing medical education, continuing education, or whether it's only used as preparatory education. And the bulk of our customers right now are pre-service training, but we do have a good number of customers that use this, excuse me, in continuing education, and we welcome that. We think it's a great program for that. It's just that our marketing and our customer support has been directed recently on pre-service programs, so that's where the emphasis is, but there's no reason they can't be used in continuing education. I think we are at time now, and so I'd like to take this opportunity to again thank Joy and Leslie and Ian and Nora for your preparation, for your good work on this. I thought it was terrific seeing a live demonstration of real teaching and learning in an online environment. So thank you for that. Thank you again to the NAEMT for helping us organize this and being a great partner in putting this on. Look at the NAEMT website for links to the recorded version of this webinar. I'd like to thank all my colleagues at ReelDx who put in so much effort to get this prepared and to work behind the scenes while we've been presenting. And finally, and most importantly, I'd like to thank everyone who attended. Taking an hour out of your day, especially given the circumstances we all find ourselves in, is extraordinary. And thank you very much for giving us your time. I hope it was worth it. We welcome further discussion about using ReelDx in your program. Please reach out to us. We will be sending emails out to you that you can respond to. You can come to our website and request a demo. You can send an email to sales@reeldx.com asking for more information. And we will do everything we can to get back to you as quickly as possible and help you move down the path of using this. So with that, I will say, please stay safe out there. Thank you all very much for your contribution to our battling this current pandemic. You all play a very important role in that, and I want to acknowledge that. And thank you all again for your time today, and we'll close it off at this point.